So tell me what's going on with Mr. Walker.
Okay, so Mr. Walker is a 48-year-old man who presents today because of a persistent cough that's worsened in the last 5 days. He says the cough is non-productive. It's not associated with fever or rhinorrhea or nasal symptoms. And he says the worsening is an increase in frequency, and it wakes him up at night. Yeah, and he says that over-the-counter medications and Mullen tea have not helped him. So he says that he's had this intermittent cough for the last 2 or 3 years. He also endorses occasional heartburn in the evenings, although he's never had to take medication for it, and it has not affected his appetite or diet. He works in construction and is currently working on the demolition phase of a historic building, and he hasn't traveled outside of the local area in the last 2 to 3 years. And Mr. Walker has a brother-in-law who has had a runny nose and a cough, but he seems to be getting better after just 2 to 3 days of these symptoms. Pertinent family history include a sister with allergies and a brother who takes medication daily for asthma. Social history, he has a half-pack year history of smoking, but he quit five years ago. And past medical history per HPI, otherwise he has no chronic illnesses, and doesn't take medications or other alternative therapies daily. On review of systems, he was negative for fever, weight loss, hemoptysis, night sweats. He had a TB test done about 3 years ago for his previous job, but he has no known exposures to TB. On physical exam, his vitals were obtained by a nurse, and his pulse was 90, respiratory rate 12, blood pressure 126/78, pulse ox 96% on room air. I confirmed the respiratory rate on my exam, and he was coughing frequently during our encounter. So on HENT, he had pink conjunctiva bilaterally in his lower lids. He had clear tympanic membranes. His posterior pharynx was mildly erythematous. On neck exam, I noticed multiple mobile non-tender lymph nodes in the anterior cervical region. They were all less than 1 centimeter in diameter, and I didn't appreciate any posterior cervical or supraclavicular nodes. On lung exam, they were clear to auscultation bilaterally. I didn't hear any wheezes on deep breathing, but I didn't ask him to do forced expiration. On cardiac exam, he had regular rate and rhythm. His pulse was 88. No murmurs, rubs, or gallops. PMI was palpable in the mid-clavicular line of the fourth intercostal space. And on abdominal exam, I couldn't feel the spleen tip, and his liver edge was palpable 1.5 centimeters below the right costal margin. So in summary, Mr. Walker is a 48-year-old man with a chronic history of cough who presents today due to acute worsening over the last 5 days. He denies any fever or weight loss, but he has noticed swollen glands in his neck. He doesn't really have any other chronic medical illnesses besides occasional heartburn, and he works as a construction worker, currently in the demolition phase of a project. So I think the most likely cause is probably allergies or reactive airway disease due to environmental exposures from his work. He's never been diagnosed with asthma, but the chronicity of his symptoms makes me think reactive airway disease. I didn't hear wheezing on my exam. I'm not sure if his expiratory phase was prolonged, but he does have a sibling with allergies and another one with asthma and takes medication for it daily. He has occasional heartburn, and he had mild erythema in his posterior pharynx. So I think his GERD could be causing his cough or contributing to the reactive airway disease. And lastly, he's concerned about lung cancer. He doesn't have fever or night sweats or weight loss or hemoptysis, but he does have the anterior cervical lymphadenopathy. But they were mobile and non-tender, and I didn't appreciate supraclavicular nodes or hepatosplenomegaly. But he does have the half-pack year history of smoking, but otherwise no additional factors that would increase his risk. So I think we should start by getting a peak flow measurement, followed by 2 puffs of albuterol, and then recheck his peak flow to see if it improves after bronchodilation. If it does, I think we can start him on an inhaled corticosteroid for maintenance and albuterol every 4 hours until his symptoms resolve. And I'd like to see him back in a month to recheck him. And I wonder if we should get a chest x-ray, given his concerns about cancer and the chronicity of his symptoms as well as the lymphadenopathy. What do you think, Dr. Wood?
I think we should go in and see Mr. Walker and share with him the plan and use the opportunity to reassure him.